here and introduce you with your bio. So many of you will know Dr. Peter Nord is currently Chief Medical Officer at MedCan. Dr. Nord trained at McMaster University and the University of Toronto. He went on to hold senior leadership positions in the US with several health systems and was medical director for Anthem Blue Cross for a number of years. From 1998 to 2000, he was also the president of the Flying Hospital, an international humanitarian relief organization bringing care to vulnerable populations in third world regions. Prior to becoming Chief Medical Officer at MedCan, Dr. Nord was VP Chief Medical Officer at Unity Health Toronto, serving on the executive team with shared accountability for clinical and operational aspects of the new merged organization. He was site lead for Providence Healthcare with operational oversight of several departments, including infection control. He is the founder of Stillbrook Accessible Retirement Residences, a registered charity focused on developing affordable retirement living communities for lower socioeconomic seniors across Ontario. He co-chairs, as if that's not enough, ladies and gentlemen, he co-chairs the Rehabilitative Care Alliance and is an assistant professor at the University of Toronto as well. So Dr. Nord, I hope I did your varied experience a bit of justice there. You have an incredible background, and thank you so much for taking the time to join us.
Thanks, Alicia. Sorry, yeah, that was way too long. We used way too
but
much.
It was necessary. It's very impressive. I had to give it my all there.
It's varied, if nothing. So great to be here, and so it's been great working with Royal LePage and the different hats that I wear. As Chief Medical Officer at MedCan, it's part of the day-to-day operations in terms of helping to develop products that are high quality, working with all of our physicians to make sure that all of our customers, all of our clients have a great experience. As you mentioned, the annual health assessment is sort of how the business was founded, but we've expanded. We have 20 or 30 different programs now, and we want to try and create almost a sort of a one-stop shop for all healthcare needs. So that's where we've kind of evolved a number of different programs, the year-round care clinic as well. So it was in that job, that's sort of my day job right now. And then this COVID thing hit back in January. And so part of my role at MedCan was to develop and lead the coronavirus working group. And we were starting to make sure that for our own company, we were, lockstep, being as proactive as we could be at the time in terms of getting policies in place, protocols in place, because we knew it was going to be coming. We just didn't know when. And about the same time that was going on, we have a number of large corporate clients, just like Royal LePage. And a lot of those clients started reaching out to us and saying, wow, is this thing real? Should we be worried? Is this something we should be thinking about? We don't have a lot of medical expertise. That's not what we do. Could you help us with that? And so we, almost in parallel, while we were building our own program to look after our own staff, we were also at the same time hearing the same needs on the part of a number of different corporate clients. One of the stats that I found kind of interesting when I first got to MedCan is when you see the reach that we have, especially among senior executives, we actually are supporting those people that have an influence on 25% of Canada's GNP on any given day. So our support for the Canadian economy indirectly is something that we're really focused on. And more recently, working with those corporate clients to not just build sort of the policies, the HR policies around COVID, how are we going to deal with this? How are we going to support our employees? How are we going to communicate with them? How do we want to make sure we're going to keep them as safe as possible? And so for the last couple of months, that was the focus. And then just over the last sort of week or two, we've had a bit of a lull because, people are now kind of used to working remotely. Those systems are in place. People understand about physical distancing, social distancing, understand about frequent hand washing and hand sanitizing, and those public policies that are obviously having a really good effect right across Canada. And each province, of course, is doing their own thing slightly, but overall, we're seeing some, excellent results. And so now we're literally almost this week, you can almost feel a bit of the first time that we sort of come up for air over the last 6 to 8 weeks. And because we're sort of into the new norm of sort of business as it is now. And now what we're getting is a lot of questions about, okay, as the essential businesses list now starts to lengthen a bit, what does that mean for our business? How do we get people now back to work? What does the new work environment look like? Those
Right.
people that are working remotely, do they have to come back on site? Maybe only a percentage have to come on site. And as we start to get back to work, what does that mean? What's the pace of that that's going to make sense? Because if we go too fast, we're going to end up right back, and all of the work that we put in over the last month is going to be for naught, because we'll see the cases explode again, and then we're back sort of, 2 steps forward, 2 steps backward. And we might want to be 2 steps forward, maybe a half a step backward, and then course correct very quickly so we can take another 2 steps forward. Best case is we just keep taking 2 steps forward and really have no back steps at all. So getting the balance right between the health of our nation and the fiscal health of our nation is really important. And here's the doc who I don't read a ton of journals, but one of the ones I read is The Economist. And so,
good taste.
Yeah. And so they've done an amazing job at kind of going over that balance. And 2 weeks ago, the lead words were a grim calculus, the stark choices between life, death, and the economy. And that's sort of what we're having to grapple with now, is how do we get back to work? How do we get back to not at life as it used to be, but at least get some activity back in the Canadian economy? And this last week specifically was the business of survival. And the byline behind the business of survival is some companies won't make it through the crisis. Those that do will face a new business climate. So that's the world that we're living in. And that balance between health of our population and the health of our economy are directly tied together, more so probably than any time in our history. So getting this right is going to be key to preventing maybe a second huge wave that could happen later on. And so we want to get back to business as soon as possible, but not too soon either. So that's something that we're dealing with right now, how we've seen kind of the changing issues that as they've come along. And MedCan's been really a privilege to be working with some amazing people, and like Royal LePage, where you guys have been very proactive, getting out in front of this challenging time. Certainly, the business climate is different. Open houses now obviously are not going to be happening. That who knows when that'll come back online. That's been a key part of selling. So, little examples like that. But if you look at banking, look at the financial sector, look at the retail sector, hospitality, tourism, the cruise industry, how long is that going to take to come back? We're pretty sure that there's not going to be a return to business as it was. And so, and some organizations that can get in front of that can end up coming out of this as real leaders. And in terms of market share, in terms of innovation, in terms of culture development with our employees, be they employees or independent contractors. So there are, it's a crazy time right now for sure. There's a lot of torment, a lot of heartache out there right now, but there are also opportunities for those organizations that really want to be as proactive as they possibly can and kind of get in front of some of this stuff.
Dr. Nord, a few things that people, when you're talking about, we've been in this for several weeks now, and we're kind of starting to get used to the new norm, shall I say, which I hope doesn't last for too long. Do you have any sense of kind of how far, are we at the peak at this point in Canada, do you think? Or is this something that you think could last like into the summer from what you're seeing? And what kind of resources should people be reading to get this, like the most reliable information from?
Yeah, well, we have one of the reasons that Canada is actually doing quite well compared to some other countries is we do have sort of a universal healthcare system and a universal kind of approach to managing. And certainly every province has accountability for healthcare and public health, even though we have sort of federal oversight over a lot of that. But as we've seen, one of the things I think the benefits and that has really made us a success so far is that all the premiers have been working together very closely with the federal government and really tapping into the same sources of wisdom. The data that they're using to make decisions is the same, which isn't to say that the decisions are the same, they're not. And you can see, you know, British Columbia has done an amazing job. They've really flattened this curve right down. The new case rates and the mortality rates are quite low. Ontario and Quebec, not quite in big numbers, haven't been quite as successful as British Columbia. Probably just, you know, at the beginning of these things, if you miss a couple of days, really, the ripple effect of that a month later is actually massive. If you look at New York City and what's gone on, like, you know, they're sort of at the same scale as all of Canada in terms of mortality and such. It's incredible. They've got as many deaths as we have cases. And looking back on it, it looks like it took only a couple of sort of one-off events at very early on, combined with the density in New York City, to have really some dramatically bad results. Really, no horror stories that they really were chasing, trying to catch up, and they just couldn't get in front of the problem. Whereas we've had the benefit of getting in early, being very proactive. We have a population that's been really great at you know, sort of participating in the new public policies around social distancing, staying at home. We have employers that have supported working remotely, minimizing transit as much as possible. And so, you know, all these kind of come together to create a really a good result. And so are we there yet? We're as the numbers are looking, I think we've all heard in each of the provinces, we're at that peak, which has been better than even and at least in Ontario, the best case. We've actually beat what they thought was being the best case. So awesome. I think the other provinces are probably in there as well. And so we're there. So we're getting close to flattening the curve. And again, at first, it's just the rate of increase starts to slow, sort of week by week, day by day, and eventually get to the point where you're flat, you're at sort of homeostasis. And then eventually people are recovering and there's fewer people getting sick. And then you start to see the total daily cases start to go down. We actually, so some people think, you know, we're turning the corner and so we're going to get back to work. Well, that's true. We'll be inching our way, inching our way. It won't feel like we're doing anything dramatic at the national level, on the macro level, but at the micro level, you know, even getting back to a little bit of work, getting some revenue into small businesses is going to keep those businesses alive. And that's that critical action, is just that we can just get a little bit of activity going. People will feel better about that, but not so much that we're actually going to create more transmission and be right back where we started from. And then really it's as we get to the bottom of the hill. So, you know, we're at the top of the hill right now. We've got to get to the bottom. That's if all things go as well as they are right now, that's probably going to be June. You know, May is not going to be a magic month. You know, the sky's not going to open in May. It's going to be a lot of the same things that we're doing now in April will be in May. But by June, mid-June, we hopefully will see, you know, a real start to the decline, so that by July, we're getting to the point where we can really start to get businesses going. Now, which is great, that's part of the economic argument, but in terms of the physical distancing, the hand hygiene, the 2-meter separation, all of that stuff, that will stay intact. That's not going to change until we have a vaccine, and that's probably a year away. So I don't want to paint the picture like we're going back to normal, but we will be able to, you know, have a bit more mobility, but the 2-meter distancing will be strictly adhered to for at least a year. And I think hand hygiene is here to stay. You know, maybe after a year or two, that starts, if we're fine, everything starts to slacken off a little bit. But number one, I think there's going to be a lot of hand hygiene for the next little while. And I bet you people are going to be lining up for their flu shots this year, even if we don't have a vaccine for COVID. So there'll be some real interesting behavior changes that I'm going to see at a population level over the next number of months. So I think we're at the top of we are turning the corner, but we really have to get almost down to our starting point before we can really start to open. But along the way, as long as we can prevent the transmissions, we should open up as much as we possibly can.
And I've been seeing on the news, you know, what's happening in the US south of the border and how they're really pushing to reopen some states. When you're comparing, I guess, them with us, do you think that maybe that's a bit quick.
Yeah.
Would you?
Yeah, it's all of this is a juxtaposition between sort of science, business, and politics, and
Right,
those three have to be kind of the workout in every country, every culture is going to work out their own balance, and it
right,
depends kind of on the personalities and the lobby groups that have strength in those areas. And part of the challenge is in the U.S. is it's been a much more fragmented healthcare system and a very fragmented public health system as well compared to Canada. And as a
right,
result, you've got these tremendously bad hotspots, but there's also some states that are unscathed, and those are the ones that are talking about opening up now.
right,
Certainly, the testing has been better in some states than others as well. So for some people, yeah, we look great, but that's because we haven't tested for it. So how do we know how many cases we actually have if we don't test? And but even if you look at part of that equation, which is the death rate, death rates have been highly variable from state to state, from city to city. So if you're in a jurisdiction that doesn't have a lot of deaths or a lot of cases, maybe you should be opening up, because the harm to your population of being, very draconian in terms of how you separate and how you keep people away from businesses might actually be causing more harm than the virus itself, even on the healthcare impact. That as people are having to, put their blood, sweat, and tears into their small business, and they're watching every day, that the chance of that business failing is increasing. The mental anguish, the stress, the anxiety, the depression,
right,
that's a real thing, and you can almost quantify that. And so it's, these economic arguments, and even in the Economist magazine, they talk about that. They start to quantify what is the damage to a society when you have a mental health stress that's like this, and what's the suicide rate going to be as a result of this? How do you weigh that against saving some other lives that are from COVID as well? So
right.
very interesting sort of ethical questions, but south of the border, it's just highly variable. We see
Yeah.
some pretty terrible stories and some really good stories too.
Yeah, it's definitely very multifaceted, to your point. I had a few questions coming in, and one of the questions, and I know we were just talking about testing and how that varies, state by state, province by province. But do you feel that the testing that we've been doing in Canada so far has been sufficient to give us the proper idea of how widespread this really is in Canada, or do you think we're still a bit behind from a testing standpoint?
Well, I think we're getting there. Each of the premiers at first, each premier was almost competing against each other for resources and, having the reagents, having the test kits just available. I think everyone was a bit surprised how quickly the case rates were doubling. And so again, there was that fear that we won't have enough equipment, either the testing equipment, the personal protective equipment, ventilators, ICU beds, like all of that had to be ready to go. And it's hard to ramp up an entire healthcare system overnight. And so, so I think overall, again, if you compare where we are just globally, we're testing, a goodly amount, and over the last 2 weeks, a real improvement in the numbers of tests. So I think we're there now.
That's good. That's good. And when you were talking about the fact that we're, at the peak, if not just past, fingers crossed, I'm being as optimistic as I possibly can. And you were talking about, slowly getting things back, getting businesses open, going back to work, that kind of thing. That's, I'm assuming, to prevent any type of second wave of COVID across the country. And I guess when you were referring to people maintaining social distance, again, until we get a vaccine, that is all preventative of a second wave, I'm assuming?
Yeah, for sure. If you look at previous outbreaks, epidemics / pandemics, there usually has been a second wave. SARS, SARS-2, H1N1 had a bit of a second wave. So typically there is a second wave, and the only way we can prevent that is really by continuing the social distancing. All the public policies that we have in place right now, they clearly work. And people are almost can't say used to it, but
Right.
it's something that is bearable, that they know that there's a beginning, a middle, and an end to it. So if we start to see the case rate start to increase, then we should be able to very quickly get in front of that and really nip that in the bud.
Right. A bit of a devastating question came in from Joanne. Joanne is asking, we mentioned the 1 year time frame from now to when we think maybe there might be a vaccine, and thus we'll have to maintain social distance and those preventative measures until then. Is that really the time that we need to wait to hug grandchildren and adult kids? Like, is that something, I guess it's a tough question. It's
tough question for sure. And we're right in the, we've only been in this, I mean, globally 4 months, in Canada 6 weeks, give or take 8 weeks. And it's felt like a long time. It feels like we've been doing this for a long time. So when you say a year, it kind of is sort of like it weighs on you to think this would be going on. So I don't want to, present sort of a pretty fatalistic view of this, but that's what the science tells us. But again, between now and then, life is going to get better. Like, we are going to get out, we are going to enjoy our summer. Hopefully home sales are going to pick up as the economy picks up. So hopefully, that's good for Royal LePage. And so as we go forward, it'll definitely be easier and easier as we go forward, for sure. And then, that's the personal choices. Knowing that, then everyone can kind of make their own choices about what works for them and for their family. At the end of the day, we know from that COVID, the folks that are most affected by COVID are older, tend to be a bit sicker, more frail, those that have immunocompromised status or have other comorbidities, other illnesses that put them at risk, which is why we're seeing the hotspots right now across the country in long-term care homes. To put it into perspective, last year, and this doesn't make the media, this is not a headline, but in Canada, 3,500 people died last year of influenza A and B. So we're at the halfway point of that because of COVID. What I'm interested to see is if a year from now, after we go through sort of a full new flu season, are we going to have 3,000 deaths from COVID and 3,500 from influenza A and B? Or actually are some of the folks that unfortunately have passed away because of COVID, are those the same ones that would have passed away from influenza 6 months, as we get into next year's flu season? And so we don't know that right now, but there's a ton of research that's going into, looking at those sort of numbers and saying, are we really adding sort of an additive, like a new cause of mortality, or is it actually affecting that same population? And
right.
Horrible, but certainly makes the news this year because of what we're dealing with. But last year, still in Canada, we lost 3,500 people due to influenza.
Wow, that's a hefty number.
Mm-hmm.
We were mentioning this much awaited vaccine, and it's a when it comes to like flu vaccines and like a pneumonia shot, are those things that we think might make a difference when it comes to COVID-19, or what are your thoughts on that?
For the regular flu shot?
Yes.
Yeah, won't have any, they're completely different viruses. They're in the same family, but they're different enough that you need a special vaccine. So the influenza A and B, every year there's a bit of a mutation and we get different strains. And so the vaccine is built against sort of our best guess of what's going to hit us that year. And, sometimes we get it right, sometimes not so much. It's not as good and not as effective. And we know that, right? So last year, 35% effective, the year before that, 80% effective. We can kind of look at that over time, but it's only specifically for the influenza A and B. And, in some ways, this is influenza C, because in many ways it does behave like an influenza A or B, but there are significant differences. I think what will end up happening is as we get the vaccine against COVID, that'll be distributed globally. That'll sort of shut down COVID. And then two things are going to happen. Either it goes like SARS, where it just disappeared, and we haven't seen SARS since 2004, or else we have more of a ripple effect of mutation. We had COVID-2, COVID-3, COVID-4, the COVID mutations. But once we get going, we can actually very quickly create a large volume of vaccine for global distribution against whatever strain that is. And then eventually we put that in with the influenza A and B. So you literally would get your flu A, B, and C shot every fall, and that in the Northern Hemisphere. And then that would help to, to cover us for all of those, variances. So we just don't know what's going to happen. Is it just going to burn itself out like SARS, or is it going to behave a little more like influenza A and B, which is typically with us on an annual basis at this point?
Right. And so a lot of people are asking about antibody testing and whether or not, proven immunity could get us back into the workplace faster. Do you have any updates on antibody testing, and if that's coming to Canada anytime soon?
Yeah, so we're on the MedCan side, we're watching this very closely because we have lots of our clients asking, do you test? Are you testing? So the testing story is kind of interesting. So there's two types of tests. There's what we call PCR tests, and that's what you see that's going on right now. That's the nasal swab, the nasopharyngeal swabs that get sent off to a lab, and within 24, 48 hours, you get an answer back. And that's what's happening through all the governments, the provincial governments, and the assessment centers, the emergency departments. That test tests the actual DNA of the virus, and it tells you if it's present or absent in your body. And that is not present or absent at a threshold level. So you could have a very small amount at the beginning, let's say, of your course before you have symptoms, and you could test negative, even though the virus is replicating in your body. And then 2 days later, it could replicate to the point where it actually does become positive. So that's one takeaway on the PCR. There's sort of a threshold line, and at the beginning, you might be below that line. Then it becomes positive, and then it actually, if your immune system kicks in and starts to kill the virus, it actually then will go away. So one of the ways that we can determine if someone's safe to return to work, let's say, or into a social setting, can be that you were positive and became negative. Now we know for sure you have no virus in your system, but that's all it tells you. What it doesn't tell you is how's your immune system doing as a result of being exposed. So the other type of test is actually a blood sample. So it's a finger prick, and it's the immunity test. So as opposed to the one being either a nasal swab or saliva, this has to be a blood sample. And you get a drop of blood and you put it into a little cassette, not unlike somebody who's monitoring their sugars if they're diabetic. And within 15 minutes, you actually get a result that says you're immune positive. So in other words, there's enough of immunoglobulin, or we call it IgM and IgG, in our bodies that have built up to fight and kill the virus and really knock it down. So typically there's two curves. The first curve is the one I described. So you have not much virus, then a lot of virus. And then at that point, your immune system kicks in. And as it starts to get stronger, it starts to knock down the virus. And then the two curves sort of take off. So for PCR test, you can test that aspect of how much is in your system. And then as it starts to drop, you really want to have that immunity test to see how immune am I against this virus that's now out of my system. So that's really a cool test. It hasn't been approved by Health Canada yet. And there are like hundreds of people that are global organizations that are manufacturers of these tests that have lined up with Health Canada. Many of them have been approved in the US, many have been approved in Europe. So it's not that there's anything sketchy about them. We just want to be absolutely sure. And in the media, the UK purchased a very large number of these tests and had to throw them out because they turned out to be not sufficiently sensitive and specific enough to be able to hang your hat on.
Wow.
The Coles Notes version on this is that the tests themselves, the blood tests, are actually, most of them are going to be pretty accurate. The problem is the people side of that equation. So everybody mounts a different kind of immune response. Some are very dramatic response. Some are sort of not so strong. The other thing is some people, that immune response only lasts for weeks. most people it's months, and occasionally people even have that immune little state in their system and still fighting off infection like a year later. So what we don't know, again, we're only in month 4 of this, so that we haven't done any studies that have gone long enough to be able to say, on average, we're going to have a protection against getting reinfected by COVID for the next 3 to 4 months. Most likely we come up with, that's the average, but then on one end, it could be as short as a few weeks in some people that for some reason can't mount a really robust immune response. And then we have some people that have incredible immune response and it can last for many, many months. So that's the reality, that these tests are very, very helpful. They have been used to do case finding, tracing, tracking, data collection. All the epidemiology around that is crazy important on the PCR side. But when we start to match the PCR with the immune testing, we're really going to have a good picture of what's happening in an individual that can help us in terms of, again, getting back to work, a safe return to work, making sure that their immune system is strong and able to really withstand a second exposure to COVID and just sort of kill it on contact the next time.
And I mean, when we eventually do get a vaccine, is there any kind of insight into how long the protection of that vaccine would last? Like, do you see this being kind of an annual thing that we get along with our flu shot, or what does that look like?
Yeah, probably. It's hard to say right now, but the first thing is just to get a vaccine in place and then make sure it's safe, that you're not actually causing disease, because that's a reality. I mean,
right.
That's why they're going as quickly as they possibly can, but we have to be totally safe, because this is something that's going to be produced globally. So we really need to know what we're doing when we start to talk in those sort of numbers. So yeah, that's why it's going to take as long as it's going to take. I would say we probably will have, a vaccine that's probably going to rise to the top maybe as early as the fall, but it's going to take, months to be able to produce enough to get it out in distribution. So right. That's where the back 6 months from after that, and that brings us to almost a year from now by the time we get this wide distribution. And then we really just don't know. Like I said, SARS disappeared, other influenzas with us every year. I think, we are anticipating that it behaves a bit like influenza A and B on that. And so that we'll just roll that vaccine into the other vaccines, and hopefully they don't knock each other sideways when they're all together. That's another issue.
So it would be one vaccine, like the trifecta in one? Okay.
That would be a home run for sure. We don't know again if that would be the goal. That if it's something, one shot covers you for the flu season and it takes care of influenza A, B, and C.
That would be amazing. I will pray for that. Question. Cindy, actually, I think this is more of a comment than a question. Cindy is commenting on antibody testing and what an efficient way it would be to see how big the problem truly is versus the PCR testing. So she's definitely all for the approval of that. But Sue, and I think Sue has a question, and it's based on the effectiveness of vitamin C, D3, and zinc to help with the immune system to fight this. Mm-hmm. There have been a lot of differing stories in the media about the effectiveness of vitamin C in particular. What are your thoughts on vitamin minerals to kind of help boost the immune system during this time?
Yeah, so for the most part, so I'll answer it. I'll back up a little bit. So I talk about the 4 lines of defense when it comes to COVID. Our first line of defense is our national borders. And so as you've seen over the last month, we've really clamped down on those borders and trying to, again, you talked about the United States. So, what's happening down there, we don't want any transmission that's the spillover from south of the border into Canada. So that's your first line of defense. The second line of defense really is that 2-meter circle around you. So as long as people are outside that 2-meter circle, the chance of you getting any kind of transmission is actually very, very low. But if somehow that virus comes in a little close, then we have, the hand washing, not touching your face, cleaning surfaces. If we need to wear a mask, we can wear a mask, healthcare, personal protective equipment, all of that, because you want to create a barrier or break the transmission between what's happening within that 2-meter sphere and your respiratory tract. So that's the
Right.
third line of defense. The fourth line is if a virus beats all of that and manages to land in our respiratory tract, your fourth line of defense is your own health. So being as healthy as possible is going to keep, even if it's in your system, you're going to have a very mild disease, or even no, like we're finding out now, a huge percentage of people are actually completely asymptomatic. And yet, if we did that immune test on them, they would be immune positive. And they'd be shocked because I never had any symptoms, doc. Like, you know, why would I even have this test? And so there's some research coming out of the States that's suggesting that like 60% of people that test positive may have no symptoms at all. So it's a really interesting thing. It's kind of like, think about like an iceberg, and at the top of the iceberg is the mortality. We know the people that have died, and we know the people that are in intensive care units. And as we get more and more people that have sort of moderate and then mild symptoms, but what we don't know is what's below the waterline, the people that were never tested because they either had such mild symptoms or maybe they had no symptoms at all. And so we may never get to the bottom of that iceberg. We never be able to get it out of the water. So all we're dealing with for the most part is what we can see like above the waterline. And those people that are below the waterline may just be really healthy people. And so that goes to the question, how do we, maintain good health? So it's all the boring things. It means, sleep, get some great rest, look after yourself, stay hydrated, get exercise, don't smoke, look at if you have some illnesses, make sure they're in good order. If you have any breathing difficulties, make sure you're taking your medicine. All of those things are going to keep you in that and underneath the waterline, essentially. So you have very mild symptoms or no symptoms at all. Age, I wish we could turn back the clock, but we can't do that. So age is a risk factor. The older we get, the higher risk that we get. But even if we get older, maintaining a strong immune system is going to be really important. So in terms of supplements, there's been a lot of research done, and there's been nothing that's been shown in good, solid research. And there's been really good quality studies done too, to suggest that there's any one particular vitamin or mineral that's going to be like crazy important. They're all important. So all the vitamins are important. Zinc's important. All those building blocks are important. But in terms of tripling the amount of vitamin C that you're taking on a daily basis, or tripling the amount of zinc that you have in your system, that's not really going to help. And for most people in North America that have a relatively balanced diet, they're going to get enough of those things just through the normal diet. We actually are well supplied in that regard. For zinc, we need about between 8 and 11 milligrams a day. And that's, if you look at even cereal boxes and you sort of add up milligrams, we're actually getting quite a bit of zinc. And, things like beef and chicken, chickpeas, things that we would normally have. Bread has quite a bit of zinc in it. So normal.
I love that. That's great.
Yeah. So you don't have to go buy like tons of zinc. And in fact, if you take more than 40 milligrams of zinc per day, it actually negatively affects your immune system. So, overdosing actually can be a bit of a bad thing. And then, in terms of vitamin C, it's a water soluble vitamin. So by water, I mean, your body says, no matter how much I take in, I'm just going to pee the rest out. So it's all water soluble. You can't overdose on a water soluble vitamin. So that's the challenge of the vitamin C. Like people can swear by it, and that's great. And there's lots of anecdotal evidence for people that have benefit. But what you don't hear is the people that have had no benefit. And all my job is to separate fact from fiction and look at the research. And all I can say is there's really been no research that there's anything that we can do other than if we're completely deficient in something. Of course, we need to make up that. But for most of us, we're actually getting most of the kind of supplements to keep our immune system just humming along.
Right. No, that's perfect. I mean, are there any, this is a question from Nella, but are there any available tests to kind of check the strength of one's immune system and kind of forecast how you would react if you did contract the virus? Like, is there any kind of benchmark?
Yeah, there actually are. And we've been We do that all the time in medicine. That we can easily check immune status and actually put a number to it, not sort of yes or no, but actually there's an amount. And it's from blood, so it's a blood sample. It wouldn't be kind of a saliva or a nasal swab. But again, so we can say, here's your numbers. Your numbers are looking really good. That's on a given day. That's on April 22nd. This is how you're doing great. A month from now, you'd almost have to have retesting done to see sort of how you're doing. And frankly, that's the research that's going on right now, where people are having tests done repeatedly over month after month after month, and they're tracking, again, sort of on average, how are people's immune systems dealing with COVID? Is it unique, or is it very similar to, let's say, influenza A and B? So that work is going on. And again, it's only been 4 months since Wuhan. So, and we would think our immune systems would be going on for at least 6 months. So those studies will probably not even start to come out until mid to late summer. But we can absolutely do that. And and we'll probably get to the point of a finger prick test, because the demand is so great that there's, again, manufacturers lining up, because the demand is just global, to come out with highly sophisticated tests that would actually become quantitative. So it's not like a pregnancy test, like you're pregnant or you're not. It's more of a, like, here's how far along you are on a scale of 1 to 10. Right now you're a 4. Take the test again in a week, and are you an 8 at that point? And then 6 months later, you're back to a 3. So that's the kind of future that we might have in front of us.
So it can fluctuate greatly from week to week, even day to day.
Yeah, it generally will be kind of a curve. It won't do that so much, but basically over time, depending how you time, you'll see, and then it'll kind of peak. The IgM tends to peak very quickly within a few days, actually, of exposure to COVID, and then gradually comes down. And the IgG, the second piece, is a little slower, a few more days, and then it hits a peak and then stays elevated again for some period of time that we don't exactly know right now, but we strongly suspect at least months.
Okay, interesting. So I'm getting some questions, and I've actually been getting a lot of questions from agents on masks and other preventative measures when out and about. What are your thoughts on masks, and are you wearing a mask when you're out and about in public, or what would you recommend to our agents?
Yeah. Well, and the story of masks has changed a little bit, and yet the basic science behind the masks hasn't. So about 2.5 weeks ago, Dr. Tam came out with a statement that maybe we should be starting to wear some masks, where that was never part of sort of public policy before. So I like to just start and think, okay, so I'm not talking about cloth masks, I'm not talking about bandanas, I'm not talking about scarves or anything like that, because I can't even comment on that because it's just so variable. There's no way to know exactly, what's up with that. So I'm going to talk about surgical masks. So, and when you think about, and you see people especially in different countries, and everybody's wearing surgical masks. Some are wearing them down around their neck, some underneath their nose. But let's just say that if we wear a surgical mask the proper way, if you think about a surgeon in the operating theater, and we've been wearing masks in the operating theater for decades and decades, because we discovered many, many years ago that if a surgeon was not wearing a mask, they were actually infecting the person that they were operating on. So the whole point of the surgical mask is to catch the droplets and the bacteria and the virus and the fungus that's in our lungs that could be coming out and infecting somebody else. It's even shaped that way. So, it's shaped to keep droplets in and protect people away from us, from ourselves. Whereas, initially people were wearing masks because they wanted to protect themselves against somebody else, what was going on. The masks were never designed for that. They were designed for one thing. Do they provide some protection against catching something? For sure, but we don't actually even test for that. So it's not a tremendous protection against actually catching something. So that's an important, and that's been there for the beginning. That has not changed at all. What has changed is when you have a population that starts to have a significant prevalence of the coronavirus in the population, at some point and I guess the other aspect, a lot of people, and you have a virus that's shed and transmitted before people have symptoms, at some point it makes some sense that people should be wearing masks to prevent the viral transmission that they don't know they're doing. So unwittingly, we know for at least 2 days before symptoms start, people are really shedding virus. And then for the first 2 or 3 days after symptoms start, also a tremendous amount of shedding. Now, if I mount a fever and I'm feeling lousy during these days, I'm like, oh man, it could be COVID. I'm going to self-isolate. I'm going to look after myself. I need to protect those people around me from my virus. But that's when symptoms start. And we know that there's a tremendous amount of shedding and of virus and a tremendous amount of transmission that happens for those 2 days at least before we have symptoms. So at some point, if that's a big chunk of the population, maybe we should those people on a more broad scale actually do need to be wearing surgical masks, but it's not for what people were thinking before. It's actually to protect people around us from our virus that we may or may not be shedding on any given day. So that's the subtleties when people are really confused about masks, and that's why it's really to protect others from ourselves in the off chance that we're actually sick and we don't even know we're sick.
Right. Okay. So do you think the government would make or should make the use of masks mandatory? I mean, we've also been hearing about the fabric masks and different types of masks. I know some people are using even construction type masks. You can get your hands on. I know that we certainly don't want to divert any N90, like any surgical masks from frontline workers. And I strongly feel that's where the masks should go. But do you think the government would be, I mean, now that, as you said, Dr. Tam was starting to talk about masks a bit more, are we going in that direction from a government standpoint?
I really don't think so. I think that's what Dr. Tam was really talking about. For certain obviously frontline workers, healthcare workers, they absolutely have to have as many of these. And even a country like Canada, we don't have the largest population. And even then it's really not practical to have, we just wouldn't have access to that many millions and millions and millions of masks. And again, to do that properly, they have to be turned over every once in a while. It's not like it would be kind of a one mask per person. That would help for a few days, and then the masks end up not working quite as well. So it's just not realistic to have a whole population where the government at least is securing those masks for those people. And there's certainly countries all over the world that are wearing masks, but they're just wearing sort of their one mask. They went out and purchased that mask for themselves because they feel they want to have that. Maybe if it helps their anxiety to wear a mask, wear a mask. But you need to understand sort of the science behind that, and when you really should be wearing a mask, and then when you shouldn't. We have a couple of very large clients that are customer facing, and these days, that's customers are looking for people that are interacting with them either on a retail basis, on a grocery basis, on a food service basis. They're going to want to see that they're wearing a mask to protect the customer from that hypothetical sick person that doesn't even know they're sick. So those folks, for sure, that's a business decision that people need to make sort of on a case-by-case basis. And these days, we are recommending that. And for the most part, the limited amount that should be wearing it is not going to be to the point, like as a nation, that we're not going to be having to stealing that away from our healthcare workers. We probably now, especially with China coming back online, and they're really ramping up their production of surgical masks. So we think over the next couple of weeks that issue should start to go down, so that we will have enough for sort of those key people that are customer facing, and then all of our healthcare and first responders.
Right. Okay. And I mean, we've been talking a lot about the pandemic and how it's been affecting Canada, but when it comes to the world as a whole, we've yet to see, I guess, the true effect that this is going to have on, Africa, India, for example. What does the future for them look like? And are we going to be, I mean, when we're struggling to produce a vaccine very quickly and that vaccine is potentially a year off, is this something that we're going to be dealing with for years to come in other parts of the world that are, less developed?
Well, hopefully the vaccine, when we talk about a year, that means global production and global distribution.
Okay.
So it wouldn't just be for the rich countries. It would really be wherever the need is greatest, because obviously one thing about COVID, it certainly showed us how we're all on one planet and we're all connected, because one country can do one thing. If they don't do a good job, it just spills over to the next country. We can't completely close our borders. So the world that we're in right now, this has been shown to be we are all interconnected. And so we need to get the vaccine. The initial shipments need to go to people that are most in need, and then start to work down that priority map. And that's something the World Health Organization is actually working on right now, is where are those massive needs going to be developing, and over what time period. If we look at China as sort of first in, first out, Europe, second in, second out, US, Canada, North America, third in, third out. And then if we start to look at Africa and India, how big is their curve? How long is their curve? And, how much can we get in front of that with a vaccine? So, and again, there'll be, governments will be making sure that this vaccine, there isn't sort of a cost to the vaccine, because that just doesn't make any sense at all, that people would not be able to sort of afford the vaccine. Obviously, countries to survive will need to have a healthy population. So cost won't be an issue. It really just will be create enough volume to create that global distribution, and then get it out to where it's most needed. And frankly, that actually might be India, and it might be Africa as much as it will be New York City.
Right. Question for you from Maria. We've had news reports of younger people, like younger ages, dying from COVID-19 with no underlying medical issues that they're known of. How can that be explained? Is it kind of differing strains of COVID-19 that are affecting different areas of the country, or how can we explain young deaths?
Yeah, that's a great question. And they're probably, well, we know for sure there are very small mutations that have happened already, but they're really not really enough to say that's a new strain that's affecting people differently. So,
got it.
So theoretically, yeah, there might be some variability there, but for all intents and purposes, it is the same virus. And yes, there have been, horrific stories of people that have been young and have passed away. A couple of reasons for that. Number one of the things we've discovered is people do worse if they have a massive viral load, or the transmission of a lot of virus in a short period of time. That's something we discovered. So if a young person has sort of say a normal exposure, they're typically going to have no symptoms to mild symptoms. 3 or 4 days they feeling kind of crappy, and headache and fever and cough, and then they're better, and their immune system is charged. If somebody was to get a very massive, a high dose of virus, at that point their immune system kicks in, but sometimes it doesn't kick in sort of quick enough compared to the dose that they've got, and they end up not doing well, and they end up having severe disease. And again, in a rare situation, we've had people that have passed away. Now, the media will certainly highlight those cases, right? So they're going to sound like it's maybe bigger than it is. It's extraordinarily rare, right? So, and in some of the situations and I've actually seen a couple of cases where they've said this person died, they were 32 years old, and nothing wrong with them, they were completely healthy, but they were actually quite overweight. And we have found some good studies that even having a BMI, or a basal metabolic index, kind of a heavier person with more fat content, will actually do worse than somebody who's thin, or thinner. And so there are some studies looking at obesity as a risk factor as well. Asthma, some people may have a very slight asthma that doesn't even need to be treated, but that can actually put them into a risk category, even if they're younger. So when they say they were completely healthy, they might have thought they were completely healthy, but there might have been something underlying occult, sort of below the surface, that was lurking there that didn't come out? You know, were they a smoker? You say, well, they were healthy, with nothing wrong with them, no illness, but they smoked half a pack a day. Okay, that might not make the news, but that would be enough to put somebody into a severe category instead of a mild category. So not to say that it's not going to happen, but there are some very subtle risk factors that are certainly present, and we're learning more and more about those. And those may be explaining a lot of those. And ultimately, you know, there's going to be that rare situation where somebody just is actually healthy and well and no risk factors and passes away. We just don't understand that, but it is exceedingly rare. The average age in Canada of the deaths is 80 years old. That's the average. And
Wow.
a lot of the deaths are over 80 as much as they're under 80. And 85%, I think, are over 65 years of age. So, you know, which means there are some younger people, but it's way predominantly a seniors issue for the people that are doing extremely poorly and need to be on ventilators and unfortunately may pass away.
Right. And so we've got about 2 minutes left. I just want to ask you before we close, obviously this is a stressful time for everyone and people are looking for kind of ways to cope with this, with, you know, the times that we're in. What would you say to people that are, you know, from a mental health standpoint, some coping strategies that you found effective in dealing with this?
Yeah, I think it's the same sort of things that we want to on a day-to-day basis. Everything's just been exaggerated now. So, you know, mindfulness, stress management, exercise, whatever we can do in the home. There's been lots of apps to help with that. Lots of virtual working out that we actually have in MedCan. We actually have a massive fitness program, and that on a dime, instead of being on site downtown Toronto, is now all virtual. And we're doing hundreds of outbound fitness assessments and therapy sessions through our sports medicine program, all virtual, so in people's homes. So there is opportunities like that. Obviously, sleep, get your sleep, good nutrition. One of the positives that we're seeing right now is people are eating out a lot less, even if they are taking out and getting delivery. So they're actually eating better. And we're finding that there's some benefits to COVID just because, you know, people are home, so they have more time to cook, do a nice home cooked dinner, which tend to be a little healthier than what we might get if we go out for dinner. So those are the kind of things they'll definitely help. Exercise, and you know, thankfully we're getting into some nicer weather, getting outside, obviously fresh air, social distancing has to be maintained, but really just getting out a bit more and enjoying the outdoors. Balanced diet, as we're talking about from a supplements perspective, that's all going to help. And then, you know, socially connecting with people that you love. Obviously, you know, we're meeting here by Zoom. I was connecting with friends down in Virginia a couple of nights ago by Zoom. We've never done that before. It was always just a phone call. So things have changed. So stay connected. If you have any, you know, issues with mental health issues, certainly employers offer a lot of EAP programs. There's lots of supports there. Just reach out. At the very least, your family physician can connect you to whatever, you know, supports that you need. That's always a great start. I'm a bit biased being a family doc trained, but that's always a great start. But I guess the big takeaway is there's lots of techniques to help, but don't keep it to yourself. If you're not doing well, be sure to reach out. There's tons of supports. There's lots of people to help, and just don't suffer in silence.
Awesome. Well, thank you. Thank you so much. When it comes to the offer that our Royal LePagers have from MedCan, more information on that offer can be found on rlpnetwork.com. And we'll make sure that we share that information with you in our closed Facebook groups as well. So Dr. Nord, I wanted to thank you so much for taking the time out of your busy schedule. I know you had 2 to 3 other webinars before this one. So I know you're a very busy man. Thank you so much for all that you do. I know that you were actively in the hospital the other day on the front lines. So thank you so much. We really appreciate it. And we hope to talk to you soon.
Good, thanks. It'd be a great pleasure.
Thank you so much, Dr. Nord. Take care. Thank you everyone for watching. Our next webinar will be tomorrow, 2 p.m. Eastern time. The Maintaining Momentum webinar topic will be personalizing your RLP Sphere websites. So don't forget to register and we'll see you then. Thank you.